This is the Kratom Science Podcast. I'm your host, Brian Gallagher, blog and social media writer for KratomScience.com, your source for all things Kratom.
My guests are two addiction psychiatrists, Dr. Cornel Stanciu and Dr. Thomas Penders. I responded to a webinar they gave in episode 38. You might want to listen to it. I thought they overstated the dangers of Kratom and wondered why you'd prescribe buprenorphine for Kratom withdrawals. We talk about that and the topic of Kratom and addiction in general. Okay, so it was a few months ago there was a webinar. It was a professional webinar, but I saw it in a Facebook group that some of the Kratom advocates were posting in. So I went in and listened, and I kind of got the idea that they were probably maybe sending you weird messages or something like that. But I was like, well, I don't think it's a good idea maybe to antagonize doctors. So I wanted to do a podcast about it. And I picked out a couple of things where I thought, that's not right or whatever. But I didn't want to have it a us against them type of thing. So I hope you understood that. And I kind of had a little joke about dunking on you or something in the podcast, but that was a joke because I'm a blogger. But what I wanted to do was kind of convey to the listeners that let's listen to doctors, even, if don't see them as against, our advocacy. So I'm glad I didn't get to do the follow-up webinar, but I'm glad we're able to do this and communicate. And I guess maybe we could start off. You can introduce yourselves and just talk about the type of work you do. Then I wanted to talk about addiction in general a little bit, so we all know kind of what we're talking about when we talk about addiction. And then we can talk about Kratom addiction specifically, if that's okay with you. But Dr. Stanciu, I guess if you want to go first and just introduce yourself and talk about where are you from and what you do.
Sure. So I do want to piggyback on what you said about some of the discrepancy from the Kratom community and the physicians.
Yeah.
But I'm Cornel Stanciu. I'm an addiction psychiatrist, and I'm based here in New Hampshire. And I would say that I have been introduced to Kratom about 6-7 years ago. It was actually through a patient that I was treating at the time. That's when I first learned about it, and since then I've been reading up on it, been informing other physicians about it, and I think both myself and Dr. Penders just grew along with the literature. There's been quite a bit of publications in the last few years, and we're part of that movement as well.
And Dr. Penders, you're in North Carolina?
Yeah, I'm in Eastern North Carolina. I'm a full-time psychiatrist practicing in an addiction setting at a program called the Walter B. Jones Center, where we admit people who are generally in pretty bad shape as a result of addiction to a variety of substances, everything from marijuana, alcohol, of course, opiates is a big deal, and more methamphetamine. And we do see people coming in with Kratom who believe that it's causing them serious addictive problems. So I've had about 40 years experience in this area, and my primary work now is clinical, that is working with patients who are struggling with addiction.
Okay, great. And when we talk about addiction, what is the medical definition of addiction?
Well, there are a variety of fairly complex definitions of addiction, but I like to make it really simple. So when we're talking about the various substances that cause us to feel good, to have an effect that's a euphoric effect on us, and we all, most of the people in the United States use substances of various types to change their mental state. when people use these substances recreationally, they make them feel good, and then they go back to work or they go through their daily lives and they feel good. There's a certain percentage of people who use these, who begin to use them compulsively, and they then find that they're no longer using the drug to feel good, but they're using the drug to feel normal. In other words, if they don't use it, they're feeling very badly, and they're sort of need to use it in order to have a sort of normal feeling about their lives. But they're really trapped in an addictive cycle where they're very, very dependent on having this drug, and their life becomes increasingly constricted along maintaining the use of that drug and frequently recovering from the use of it, and then the devastating consequences that occur as a result of the constricted life that they live that way. I know I think that would be the simplest way for me to explain how we see the addiction condition.
What's the source of addiction? I mean, is it sourced from the use of drugs? Because if that would be the case, I would think everybody who ever used any drug would become addicted to it. Or is it sourced from maybe past trauma or maybe a genetic predisposition?
Yeah, there's definitely a variety of factors that can influence the course of an addictive disorder, but also vulnerability to it. As you mentioned, trauma certainly is one that predisposes individuals to try and self-medicate with various illicit substances. Certainly having a genetic vulnerability, almost a distorted circuitry in their brain that predisposes them to advance much more quicker from use to that addictive cycle also plays a role. But it all starts with exposure to the substance. That's what tends to trigger the majority of addictions. And then how that progresses from there is dictated by the individual's environment, by the individual's underlying neurobiological underpinnings, genetics. So it's certainly a multitude of factors, but again, it all starts with exposure to the substance.
Brian, I would, I'd like to just say here that over the past 25 years, we've learned a lot about the neurobiology of addiction. And we do know that all drugs that have the potential for producing the addictive syndrome have effects on a certain part of our brain that is responsible really for motivation, for pleasure, for reinforcement of pro-social behaviors, if you will. Mm-hmm. So individuals who are vulnerable have some vulnerability within that neurological system, but they also have social vulnerabilities, obviously. And so it's somewhat complex, but it's not so complex that we can't understand it.
I think also a big distinction should be made between the various levels of substance use. Not everybody that uses a substance has an addiction. There's substance use, there's abuse, and then there's addiction, the highest level of them all. And one aspect that I think a lot of times, I know, for example, on your blog, we see a lot of patients that do report benefit, that do report a lot of success stories. Mm-hmm. And like I indicated, these are not the same individuals that we tend to see in our clinic. We see the ones whose substance abuse has progressed to a level of addiction, side effects where we need to intervene medically.
Yeah, and that was my follow-up, is there such a thing as responsible youth? And we were hearing a lot of successful stories, like people were using Kratom as maybe, almost like a exit ramp off of harder drugs, and we weren't seeing that reflected in media. There seemed to be kind of like a, sensationalistic drug horror story type of strain going through the media, and just to balance that out, there was a lot of people that seemed to be, a lot of people say that, it saved my life, and there's so many people that are saying, I was addicted to opiates, and I discovered Kratom, and now I can function, and so that's kind of where I am with the blog, with highlighting like the positive stories. But I know there is Kratom addiction, and I would you consider there's such a thing as responsible substance use, or would you just, or is it ideally people would not use substances at all?
Look, the use of substances have been part of human nature as far back as history is recorded. So, yeah, there is a spectrum from, I guess, what you would call social use. I don't know why you would want to use the term responsible, but
yeah,
the purpose is to alter your view of the world, really the way you feel about the world. So that can occur in social responsible situations, but it occurs along a spectrum of individuals who may use in what we would call a high risk way. Mm-hmm. So they're used responsibly, they're using larger and larger amounts over time. And that's when we get concerned about preventing their transition into the addictive syndrome, which is very destructive to individuals' lives. Mm-hmm. So clearly, the vast majority of people who use substances, and you have to to some extent be aware of what substance you're talking about. So if you're talking about marijuana, there are a lot of people who use marijuana who don't get in trouble for using marijuana unless they're in trouble legally because it's illegal. Mm-hmm. You want to call it responsible use? I'm not going to argue with you about that. Obviously, there are a lot of people who use alcohol responsibly.
Yeah.
And there are a lot of, but can you say there are responsible smokers? Can you say they're responsible cocaine addicts? And as we look at the various addictive substances, I don't know where Kratom falls into that spectrum. Clearly, there are a lot of people using it, as you say, and claim to be having a lot of benefit from it and not really getting into trouble. But as addiction psychiatrists, we're dealing with the people who are getting into trouble.
Yeah. That's important for people listening to this to remember. If somebody's going to the doctor and saying, this stuff, I can't get off this stuff, then you're not seeking Kratom consumers out and saying you're an addict. You better, get to my doctor's office and we'll. Yeah.
Not at all. In fact, it's quite remarkable that the majority of individuals who are using Kratom for pain relief, which is the most common reason that I understand that the surveys suggest that it's mm-hmm. being used, are sharing their Kratom use with their primary care physician. So they must have some, at least, agreement with their primary care physician that that's okay. So physicians are not frowning upon everybody who's using Kratom. Our job is to warn people about the risk side of things, and maybe not so much, unfortunately, on the benefit side of things.
And I think there's no doubt that individuals that are using and reporting benefit, there's no doubt that perhaps there might be maybe one of the many constituents of Kratom may have some therapeutic potential. We don't know that. About 40 to 60% of the currently available medications behind your pharmacist's counter are derived from botanicals, but these underwent rigorous trials, and they were evaluated very carefully, not just for efficacy, but also for safety. Not to go on a tangent, but just to use an analogy, there was a British physician in the 1700s that was dealing with a caseload of patients with heart failure who are not responding to the currently available pharmacological modalities. And he did notice that one of them was doing really well. And after talking to him, he found out that he was using this old herbal remedy from the foxglove plant. So he started endorsing the use of the foxglove. Everybody was on it, doing well. But because of the variations in the constituents, very much like with kratom, there's a lot of components. They vary tremendously. Because of that, he found mixed results. Some were doing better than others, and ultimately he realized that some patients were also dying. And later on, through research, they found out that the toxicity index of the foxglove plant itself is very close to the therapeutic index. Later on, they were able to isolate the cardiac glycosides, digoxin and digitoxin, and they're still used right now in medical practice. But that wasn't without the rigorous trials. So I just want to put it out there that kratom as a botanical, certainly I do have concerns about some of the patients, my patients that are using it. But at the same time, I want to be open-minded, and I want to say that perhaps through further studies and investigations, we may determine that, say, mitragynine may have some therapeutic value. But for that to happen, we need the good rigorous trials. We need to be able to determine exactly the dose, the frequency of administration, which conditions benefit from it. Because us as physicians, we want to be able to replicate the treatment outcomes and also to have predictable treatment outcomes as well.
We're looking at a study that went back to 1972 when they were looking at mitragynine as a sort of treatment option for morphine and withdrawal, much like buprenorphine and Suboxone is being used now. That's kind of the whole thing. It seems like it's not going to be developed like that unless there's kind of a profit motive there, and that's kind of another issue because, you know, a lot of people, they have access to this stuff and it seems to be relatively safe. However, as long as it's used in low doses, I think a lot of people are using way too much. Traditionally, they brew it into a tea. I mean, it's all leaf material that we're getting, but it could be adulterated. That's why the American Kratom Association is advocating for testing requirements so people know what they're getting. And it just seems to be an option for some people who, I mean, we have a lot of comments that Suboxone didn't work for them, and kratom does, and it's almost like with the opioid crisis, it's almost like we're gonna have to wait for clinical trials and everything, and the process for it to be developed into a drug. And there's a question of, should we be able to access this legally? Do you think drug policy as it is now hurts people seeking treatment for addiction? Do you think cutting off access to kratom until it gets developed through clinical trials is the right thing to do?
Yeah, so you're asking a question of public policy, and
yeah.
We, as think of ourselves as scientists who are interested in clinical treatment of patients, we can inform those who make public policy about the potential benefits and risks of various substances. So in the case of kratom, what do we say about the benefits? Because, as Cornel points out, kratom, there isn't just one kratom. There's a whole variety of different varieties of kratom and preparations for kratom, lack of standardization, which makes it difficult for us then to advocate for the use of kratom if we were talking to a legislator who's considering this.
Sure, yeah.
And when the legislators just ask us, what do you think about the dangers of this substance? Well, we're aware of those dangers, and we tell them about those dangers. So our opinion about whether it's wrong to cut off access to kratom or its right to cut it off is really irrelevant. We don't make those decisions. So you're asking me essentially, do I have a liberal or conservative point of political view? And I don't really think that it's relevant to my training to be able to comment like that. You follow what I'm saying?
Yeah, sure. I'm just thinking in terms of how a drug is developed. Yeah, I mean, maybe this goes outside of, what you guys care to talk on. That's fine.
How about if we approach it like this? How about
Sure.
if my brother-in-law, and right now I don't think I even have a brother-in-law, but suppose my brother-in-law says, listen, I've had this chronic back pain for a long time, and for a while I was taking Percocet, and then the doctor wouldn't give it to me anymore, and I started using these pain patches, and they didn't work too well either. And then I started taking kratom, and boy, I'm really feeling a lot better now. I get pain relief, and it's not too much of a problem, and the kratom doesn't bother me very much. And he wants some advice from me. What am I going to say to him? And I would tell him that if it's helping him, well, I'm really pleased to hear that it's helping him. But be aware that we have some reports that occasionally people are developing, if they use large amounts, they're developing liver disease, and it does have some potential for addiction. So be very, very careful about it. So on a personal level, I wouldn't get it. I wouldn't be all upset that my brother-in-law was using kratom, but I would express my concerns about it, given that I cared about my brother-in-law.
Yeah, and I think, Brian, when it comes to that, we as physicians, we took the Hippocratic oath, primum non nocere, first do no harm. So unlike the kratom community, our first concern is regarding the safety of any of the recommendations or any of the things that we support in the care of our patients. And in the scientific community, there's different tiers, different levels of evidence. The lowest one being expert opinion, case reports, a lot of things that we may hear about from things such as the endorsements of the kratom users. Then we move on to things like case series, smaller cohort studies, and then randomized controlled trials, where we enroll humans to determine both the safety as well as the efficacy of a medication. And for kratom, we just don't have that type of studies. You did point out that there are some in animal models where they have used mitragynine extract to see if it's a safer alternative to opioids. Mm-hmm. And there's a lot of concerns with that. I have seen some data that there may be some interspecies variability with regards to how something like mitragynine, for example, might act at the receptor level in animals as opposed to humans.
Yeah.
So there are some challenges in interpreting animal data in humans. But I just wanted to give you an idea of where we come from as physicians in terms of how we see intervention treatments in the care of our patients.
I'm definitely looking forward to kratom clinical trials and all that, and I hope it happens. It's just kind of hard that I just hope there's more NIDA funding. They just granted like $6.5 million to the University of Florida to study it, and it just doesn't seem like, if a drug company doesn't want to develop it, then it's not going to be developed. As far as your patients with kratom addiction, most people are saying, well, the withdrawal is nothing much. It's just like coffee. I might get a little irritated or anxious for a couple days. This is what I was probably wrong about in the podcast I did on the webinar. What you're seeing is people are having more severe withdrawals. And as I was looking at paper you published and some more stuff, there is cases of people that are getting sick and having more of an opioid-like withdrawal. Is that the case with the people you're treating?
Dr. Penders, you want to take that?
The short answer is yes, although I'll let Cornel tell you about the survey that we did of addiction providers across the country?
So I think, again, I think I mentioned this at the beginning. I think we deal with a different type of individuals that they use Kratom. I think the individuals that we deal with and come to us for help are not the ones that are going to come back to you and be able to share their experience on the blog. So there is a little bit of a disproportionate patient population there. But what we have seen is indeed the withdrawal can be quite significant, and it really depends on one's amount of Kratom use. It really depends on the duration, and it's definitely it's very distressing. Mimics opioid withdrawal very much so, and a lot of individuals tend to return to use. I have seen some data from Southeast Asia where they say that the relapse rate at 3 months, relapse to use after just a detox, can be in the 90%.
Mm-hmm.
So individuals really do have a hard time staying away from it. And we did a recent survey of addiction experts across the country just to get an idea of how common Kratom use is within their patient population. And we saw that quite a few of them, a significant amount, have encountered individuals who use Kratom. Not just in the setting of an opioid use disorder. So not just individuals that are looking to transition from opioids onto Kratom or trying to get off Suboxone or something else, but also individuals who are trying to manage other types of condition like anxiety, insomnia, depression, ADHD. Those are pretty common as well. But at the same time, when it comes to treatment, the experience of all these addiction experts has been the same. They all, especially the ones that are using a higher amount of Kratom, do tend to have this really significant withdrawal and difficulty staying away from Kratom. And they have used some of the same medications as those in opioid use disorder. Obviously lower dose if it's just addiction to Kratom and not to opioids as well. But those have been effective at helping individuals reach their goals of sobriety.
In the webinar, you suggested using buprenorphine to help people on Kratom withdrawal. Is that just during the withdrawal, or is that kind of like a plan to stay on buprenorphine after the withdrawals are over?
So currently there are no guidelines. That's part of what we're trying to establish, some kind of standard of care for patients with Kratom addiction. But currently there's absolutely no guidelines on how to manage it. What we have observed is that for withdrawal management, buprenorphine works well, and we have also seen through literature review some of the cases that exist, as well as discussing with our colleagues in addictions that they have used buprenorphine, they have used naltrexone, some even have used methadone, very, very few. But they have implemented these medications in an effort to help the patients achieve their goal of sobriety from Kratom. How long term, we don't know. All we can see is that they have used it as maintenance treatment.
I mean, that one, my initial reaction, I'm trying to learn here and everything, but it really seems like, because I've heard from people that had, methadone horror stories and buprenorphine, Suboxone, and, who said, well, Kratom worked to get out of that. It just, it struck me initially as, the cure's kind of worse than the disease there. Isn't that risking getting the person addicted to, stronger opioids?
Well, it's an evidence-based modality, and I wouldn't call it that the individual would be addicted. The individual would continue to be dependent
Okay.
on something that activates the opioid receptor. So it's not like we would be the individual would all of a sudden transition to something that's more addictive. And in terms of potency, some of the data that's out there is that the way some of the alkaloids of kratom act, they can be more potent at some of the opioid receptors compared to buprenorphine and other more traditional opioids. But again, it depends on how we want to work with the individual on their goals and how they feel about wanting to get away from kratom and onto some more evidence-based modalities that are out there.
Yeah, I think something that Dr. Stanciu said is very important. Is this in your understanding the physician's standpoint here, and that's we have the opioid problem, which clearly is a tremendously serious problem that continues to wreak havoc on a large proportion of our population, and we have medications now that clearly have been shown to reduce some of the complications that occur in the lives of individuals who have had opioid problems in the past. Mm-hmm. We're not putting kratom in the same bucket there.
Okay.
But we're not putting it in the same bucket because we just don't know.
Yeah.
And when physicians relate to patients and give them recommendations, we believe they should be, quote, evidence-based. And so when it comes to kratom, we don't really have the evidence. So it's hard for us to advocate for the use of kratom if we don't have evidence that it's safe and effective.
Mm. Yeah, I understand that. And I mean, the one thing you said about it being kratom might act stronger on the receptors, I mean, the research I looked at, it was from Krugel, and I believe it was, you might have referred to it in your paper or on the webinar slides. It looks like at the opioid receptor, it works in such a way that produces less side effects like respiratory depression. This is what Krugel's paper said. So
that's right, because but that has to do with the internal signaling pathway. So what happens at the cellular level once the receptors are activated, and that looks at mitragynine specifically. What I have seen in these animal models, I must say that personally I am somewhat intrigued about the potential for any therapeutic benefit with mitragynine. But as for kratom as a whole, as a plant, in the patient population in humans, certainly there are significant concerns, not just for addiction, but also I'm sure you've seen the liver toxicity reports, the problems that exist with various interactions with other medications individuals are on, and also with the quality control of the products. I think you mentioned the Kratom Consumer Protection Act, which alludes to that as well. But to go back to what you have said, mitragynine does bind to the opioid receptor just like other opioids. But what happens from there at the cellular, within the cell, what type of signaling pathways get activated? It certainly seems like it takes a different route, the traditional opioids, to where there may be less respiratory depression compared to traditional opioids. There may be less risk of things like tolerance and dependence, but that's just with mitragynine, just one of the many alkaloids found in this botanical.
Well, I mean, there was a recent study on lyophilized kratom tea, which is basically just kratom tea, and in their conclusion, this was McCurdy from University of Florida. They got the NIDA grants, and this is one study, so I understand that, but in their conclusion, repeated administration of lyophilized kratom tea did not produce physical dependence, but slightly decreased naloxone precipitated withdrawal and morphine dependent mice. And just there's studies like that coming out. I mean, I know it's not conclusive, and there has to be more of them, but this other one demonstrated this superiority of mitragynine in relation to buprenorphine, but this one was the kratom tea. It was kratom, and then there's other evidence that mitragynine is metabolized into 7-hydroxymitragynine, which is considered the one that has more of the opioid effects. Even back in 1972, when they were doing the animal studies, the one guy that worked on it was Dr. Weinbach, who developed Lipitor. It was SmithKline and French. So, there are no slouches when it comes to pharmacology. And so a lot of people in the kratom community, there's a mistrust of doctors, I would say. Even though doctors, most of them are there to help, they kind of think they're just selling me these drugs. That used to be OxyContin, now it's Suboxone. Do you have any thoughts about that?
Oh yeah, we have a lot of thoughts about that.
Sure
There's this idea that somehow we're replacing one addiction for another. Has been around since the introduction of methadone. But we have enormous amounts of studies, evidence, personal experiences from patients that have shown that these medications can make an enormous difference in individuals' lives. The simplest way to explain this, that there's somebody who has an opioid use disorder, say they've been using heroin for 3 years, and they come into our institution and they detox. And they say, okay, I don't want to be on any of these drugs because I don't want anything affecting my brain. Their risk of relapse within the next 6 months is somewhere north of 90%.
Mm-hmm.
But if we put them on a medication like buprenorphine or methadone, their risk of relapse goes well below 50%. So the individual's risk of continuing their addiction is much higher if they don't have the medication-assisted treatment. This is what we refer to it as. And it's important for us to, that's why we prescribe these medications. We don't view them as, we don't really know when they should be stopped, because even up to 2 years, when people have an established opioid addiction, if we try to taper these medications and get people off them, which we'd love to do, I would love to do that with all of my patients, see them be drug free.
Yeah.
But if the alternative is that they return to the illicit drugs that have caused them serious problems in the past, I would prefer to continue prescribing. So, I think the difference here is not that we're replacing one addiction for another. It's that we have something that's been proven to improve the welfare of individuals who are suffering from addiction problems. And that's not true of heroin or other substances that are addictive.
With the opioid use disorder in general, individuals that are on these type of medications, first of all, one size does not fit all. It's not that everybody automatically goes on buprenorphine, everybody automatically goes on naltrexone or methadone. Mm-hmm. It's based on a determination made after careful evaluation to see each individual's psychosocial circumstances, use history, past treatment failures. So there are multiple modalities that we have to be able to face each individual in these three categories. Certainly, without any medications, as Dr. Penders mentioned, their chances of sobriety are next to none. Whereas with these medications, it can make a life-changing difference. And the theory of replacing one with the other, patients that are on methadone or Suboxone, they're able to live great, fulfilling lives. They're able to have families. They're able to hold down jobs. They're not out there looking for heroin on the streets or doing and engaging in any type of criminal behaviors to obtain substances. So they may be physiologically dependent, but Suboxone, methadone, Vivitrol allows them, or naltrexone, allows them to live a different type of life that's not revolving around the use of substances and prioritizing that over everything else.
Yeah, this sounds like a familiar story. It's what I hear a lot about of people who switch to Kratom from stronger opioids. I can hold down a job now. I'm a better mom for my kids. I mean, all these stories that kept coming in, and I'm like, wow, this is really helping people. And I know you can't, as medical doctors, you can't prescribe Kratom, but just on people's use alone, it seems like that has the potential to be a medicated assisted treatment. But I think maybe the criticism is not just of is not medicated assisted treatment that I was talking about from the Kratom community. It's more like, well, why do I have to go through a system that maybe I went through before and I came out hooked on OxyContin? Can I just buy this Kratom and use this, and use this responsibly myself? Or do you understand, though, that some people are, it costs money to go see a doctor, it costs money to buy a Suboxone. Some millions of people don't have health insurance. That's another concern. And they're kind of turning this plant medicine. I mean, is self treatment always dangerous?
No, I don't. I wouldn't take the position that all self-treatment is dangerous. I mean, if it's working for someone, they don't really need to see a physician. But if they present themselves to a physician, the physician's going to give them their best advice. And I think, while like in any profession, there are some bad physicians. I mean, most physicians are going to want to give advice that is going to be helpful to the individual who's seeking their care. I did want to comment on some of what you said about mistrust of physicians, because mistrust seems to be abroad in the land for all kinds of authority figures. And it is a problem if we look now, at the COVID-19 vaccine and the large number of people who are resistant to taking it. They seem to have a mistrust of science. And so that can easily translate into these group of people who are using Kratom on their own. And they just don't want to believe what science is revealing about the potential risks for Kratom. And I don't want to overstate the risks, but I do want to state the risks that we know about and try to hopefully work together with any individuals interested in Kratom to find out what's the best way to maximize the benefits and minimize the risks.
We don't want to hide that there are negative effects, and some people. At the same time, it seems like a lot of what the FDA did. I mean, they were talking about 44 deaths associated with Kratom. There was a scientist who, Dr. Jane Babin, who wrote a paper criticizing their study of it, and the biggest example was a patient who had Kratom in his system, a deceased person who had a gunshot wound. And it seemed like the FDA was actually trying to, highlight the negative aspects of this stuff to get it outlawed. And that's kind of is what leads to the mistrust. That's the whole thing with Kratom. It seems like there's a push to outlaw it. And that kind of leads to the mistrust. What it's going to do is, anybody that says anything negative about it, they're not going to believe them, even if it's true.
Well, there was definitely a push to outlaw it early, and the former FDA commissioner was very concerned about the potential risk. But again, you have to understand, as a regulator who's responsible for the purity and safety of the American population's exposure to food and drugs, this role is to say, if there's risk associated with this, I'm not sure why we want to make it available to the public. I'm not trying to be an apologist for him, but it definitely happened. But obviously, it was not successful because most people can get Kratom with impunity. And are you aware of a lot of prosecutions of people who bought Kratom, even where it's outlawed?
There's a lot in Thailand. I get a lot of news from Thailand, and they recently legalize it again for medicinal use. So there's a lot, and they in general they have a pretty harsh anti-drug law enforcement.
Well, in Saudi Arabia, I think you can get beheaded for drinking alcohol, can't you? So
yeah. I mean,
Brian, I wonder if you know about the differences. There was the study that came out looking at some of the more significant risks associated with the higher incidence of deaths associated with kratom in the United States compared to the Southeast Asia. And what came of that is that some of the products that are commercially available here in the United States, the kratom products, do contain significant amount of adulterants, impurities. I believe they had mentioned things like hexane, chloroform that may increase the adverse outcomes. Are you aware of what type of products are available in Southeast Asia and why? I gather some of their product is more has more of a quality control. I'm not too sure. I'm hoping you may be able to shed some light on that.
Well, yeah, I had Dr. Singh on here, Darshan Singh, and you referred to a couple of studies in your work too. He's one of the he's at University of Science in Malaysia, and he's one of the leading kratom researchers in the world. The thing with Malaysian and Thailand is it grows on trees there. They take the leaf off the tree, and they brew it into a tea fresh, and they sell the tea in they call it kratom juice, and they sell it in plastic bags. That's all they do. It's right from so there's no, what happens in the United States, most of our kratom is grown in Indonesia. It's dried and processed. So there's no standardized manufacturing process there. So it's left out to dry outside sometimes. Sometimes there's animals crawling over it, so that accounts for the salmonella. It's ground down into a powder. It's basically the same thing. It's leaf material, but in the grinding process, there could be heavy metals. They might have, ancient coffee grinders that they're using from, the 1940s or whatever that contain lead in them. So there's a concern with that, and I don't think that there's much deliberate adulteration going on. I think with the extracts, there might be kratom extracts would be a stronger alkaloid content. It would be like whiskey is to beer. But in the extraction process, there's chemicals used that might be left in the extract material. But as far as adulterating, like purposefully adding things to, get people high or something like that, I don't think there's much evidence of that. What Dr. Singh said was he doesn't hear about any of these negative side effects. Like I've heard from people that said it caused hair loss, and I think one, because it's fresh material pretty much directly from the tree. They don't even bother to dry it out. And another reason is I think when it's in powder form, people are taking heavier amounts of it. So even if there are trace elements of maybe lead in there that would be under the safety threshold, some people are consuming so much of it that they do get those side effects. And we tell people that, if you're above 10 grams a day, that's probably not so good. So we're almost coming to an hour, and thank you so much for your time. Do you have anything else you want to say about anything we talked about, or addiction, or anything?
We're on that topic of, I guess, under the general umbrella of adverse effects. Just wanted to see what your thoughts are on the reports surrounding the liver injury and hepatotoxicity that have been linked to kratom.
Yeah,
have you noticed any of the kratom members or any personal experiences that you might be willing to share?
I really don't hear much on that. I was worried about drug interactions because there's been reports of drug interactions that it might inhibit the metabolism of other drugs, so it would make the effects stronger.
Yeah, I don't know if you've heard. There's something called drug-induced liver injury network. It's an organization that's been established since the early 2000s.
Okay.
And they collect data on liver injury that's related to any type of herbal supplements, including kratom. And I think a significant amount, and when I say significant, I'm not referring to hundreds or thousands, but quite a bit of kratom-induced liver injuries have been reported to them, and these were investigated by a panel of experts, and indeed they did conclude that there's some association with that. But I didn't know if you had any personal or any user experience as to whether various strains, various doses, or any other patient-specific factors may be associated to the liver injury that can result from kratom use.
I don't think I've heard any personal experience. There might be on, there's a Reddit subreddit called Quitting Kratom. Most of the people who comment on our site, a vast majority are commenting on having positive experiences, which is strange because usually people complain on the internet. So I think the bias would work the other way. I don't really see any, but I can look for them because it's something I'm interested in and interested in writing about as well. I know Dr. Singh's study in Malaysia where he actually took blood from kratom consumers. They found no instance of hepatotoxicity. However, the Malaysian kratom it's not as strong as even kratom in Thailand, so that has to be considered as well.
Brian, I want to thanks for hosting us.
Yeah, I appreciate
it, and I think I know Cornel would agree that we would be happy to remain available if you thought that our opinions would be helpful to you in the future.
Definitely.
Absolutely. I mean, we're here to partner with you to learn from users and also to act as a resource. We're approachable, and we as I mentioned to you, I think our goals are very much overlapping with you guys. We want to make sure that patients' conditions and needs are addressed, but also to do so in a safe manner. And if obviously it gets to a point where there's adverse effects, the risk of addiction, certainly we're here to act as a resource to you.
If you have any kind of comment, please leave it. If you have experience with addiction psychiatry, kratom addiction, any other addiction, we want to hear from you. We're all here to learn and try to help each other out. The Kratom Science Podcast is written and produced by me, Brian Gallagher, for KratomScience.com. The music is by Risey. The song is called Memories of Thailand. Take care.